All right, so this is chapter 11. It's a chapter on disorders of the outer, middle, and inner ear. We also talk about the Link 6 Sounds test and how we use it. So if you remember back to speech science, or maybe that's this semester for some of you, we use the Ling 6 Sounds test to do checks on cochlear implants, hearing aids, and in the process of oral rehabilitation. And so the Ling 6 Sounds is comprised of 6 sounds: ah, e, u, s, sh, and Okay, so it has some fricative sounds. It has a nasal, and it has a front, central, and back vowel. And it has actually 2 fricative sounds, the S and SH sound. Differentiating those two for individuals with hearing loss is extremely important. And so if you look to the right, you can see the audiogram as to where most of those sounds fall. But E, if you remember, has a low formant 1 and then a high formant 2 and high formant 3, versus which is more central, which has formants that are equally distributed in terms of frequency, so they're kind of equidistant. And then U, which is a back vowel, and has a low F1, low F2, and then the F3 is a little bit higher. So go back and review these so you are familiar with the acoustics of these 6 sounds. So we're going to watch these videos during class, and I'll record it, but we'll watch this. I want you to watch it before class, but this is an example of how those sounds are used. So let's talk about outer ear disorders. Otitis externa, which is swimmer's ear. It's essentially a bacterial, fungal, viral infection in the outer ear. You can see what it looks like. This is in the external ear canal. This is not behind the eardrum. It's a health concern. It needs to be dealt with, but there's really not much concern for hearing loss unless it becomes so impacted with pus or some other kind of fluid. And so otitis externa, not really concerned about hearing loss, but concerned about just the general condition of the external ear. So again, we'll watch the video at another time. Impacted cerumen can cause up to about a 40 dBHL hearing loss. It's essentially when it blocks the passage of sound from the earphones to the tympanic membrane. And cerumen removal is within our scope as an audiologist. It's something we do. Physicians also do this, nurse practitioners and other types of allied health professionals. And we'll watch that another time. Congenital malformations of the outer ear like microtia, atresia, stenosis. Microtia is just a malformation of the pinna. Atresia is the absence of an ear canal, so that picture on the bottom. And then stenosis is a narrowing of the outer ear canal. So remember when we talked about bone-anchored hearing aids and bone conduction hearing aids? If they can't surgically create an ear canal, then a bone conduction device is a good option for these kiddos or adults. And then we're going to watch this video. We're going to go through some middle ear disorders. May involve the tympanic membrane, the ossicles, the middle ear space. They always cause at least a conductive hearing loss, meaning that some might have mixed losses, but there's always a conductive component if there's enough to cause hearing loss. So a tympanic membrane perforation, there you can see it. You can see the mucosal portion inside of here. So this is associated with trauma to the ear, explosions, different acoustic traumas, middle ear disease. Somebody could have had a surgery called a myringotomy, which we're going to watch. A myringotomy is a small incision to remove fluid, and then they put a pressure equalization tube in. Well, sometimes the eardrum doesn't heal completely, and so you have what's left there. And hearing loss may or may not accompany it. It depends on, there's a whole host of factors, but tympanic membrane perforation, if a hearing loss is present, it's conductive. Again, we'll watch some videos. Otitis media is essentially a inflammation of the middle ear space. Otitis media with effusion, OME, refers to when there's fluid in that space. Otitis media in general without effusion can just be an inflammation, but whenever there is effusion or fluid present, that's when the hearing loss typically occurs. So here's some acute otitis media pictures. At the bottom there, you can see it's red, it's inflamed. The top is the normal tympanic membrane. You can see the middle ear bone here, okay, the manubrium that attaches. You can see this, what's called cone of light, which essentially is a light reflex bouncing off of the bony part. And you can see the annular ligament, if you remember back to anatomy and physiology. But here's an acute case there. Here's an otitis media with effusion. You can actually see the air bubbles, and the video we have shows you can see them as well. So there is otitis media with effusion. Management of otitis media, sometimes physicians will prescribe antibiotics if they feel like there's an infection, like a true infection, not just that fluid. So this fluid is unlikely to be infected here, but depends on the judgment of the physician. Different things they do are myringotomies. That's a surgical procedure which we'll watch, and then a PE tube. And again, I want you to watch these videos before class if possible. Yeah, we'll watch that. We'll watch them put the tube in. So usually there's a 25, 30, 35 dB conductive hearing loss with otitis media. And usually acute otitis media occurs and then the fluid builds up. So here's an example of what we would see diagnostically. And this is from the text. So this is air conduction or bone conduction, unmasked and masked. So what you really need to look for here is the presence, I'm going the wrong way. The presence of the air bone gap. Oh heavens, sorry. But here you can see the gap between the air conduction and the bone conduction score. Same here. Don't worry about the reflexes. But here you see flat type B tympanograms, reduced tympanic membrane mobility or compliance. Ecclesiotoma is essentially a growth of skin or some kind of cyst in the middle ear space. And it's almost always required, and there you can see a picture there, required to be surgically removed. Just a heads up when you watch this video, there's a good bit of blood and so forth, so if you get a little queasy, just be advised. But they show you how they surgically remove a ecclesiotoma. Some of the health complications can be dizziness, facial nerve weakness. So if that piece of that cyst or growth hits the facial nerve in the middle ear space, it can cause facial nerve weakness or paralysis. There's other life-threatening things that can happen with it. So the ecclesiotoma is really important. They're almost always willing to sacrifice a person's hearing when there's a ecclesiotoma because it can grow into something that could be very lethal for the patient. And usually it's on the line of conductive loss unless it's grown into the inner ear. Ossicular chain fixation. This is essentially when the footplate of the stapes is stuck in the oval window. And it's just a reduction in the physical transmission. So obviously it causes conductive hearing impairment. Otosclerosis is the most common type, and that's when you get sclerotic bone around the footplate of the stapes, becomes spongy, and then it gets hard. It doesn't allow that ossicular chain to vibrate. And here somebody's going to talk about that. Now, typically with otosclerosis, you have a type A sub S tympanogram. because it's very shallow. It's shallow because it's extra stiff, okay? And you can have some conductive hearing loss with that. So again, for middle ear disorders, our job is to detect them, describe them, test them before and after medical management. And then sometimes we will fit different types of devices if the conductive loss is not able to be corrected medically. So inner ear disorders, these are related to function of the cochlea or auditory nerve, causes sensory neural hearing loss as opposed to conductive. Conductive hearing losses rarely exceed 60-65 dB, but sensory neural hearing loss can be severe to profound, permanent. Most times it is irreversible. Most common types are noise-induced and presbycusis. Noise-induced hearing loss, and we have more on an additional presentation. But noise-induced hearing loss is 100% preventable. It is commonly caused by occupational noise, but can be caused by recreational activities. So I used to see patients all the time who would say, oh yeah, I always wear hearing protection at work. And then we talk about what they do at home, and they would do target shooting, different things, and they wouldn't wear hearing protection or listen to loud music and concerts. And so it's not just about occupational noise exposure. You have to think about the recreational noise exposure. Presbycusis is essentially hearing loss caused by the normal aging process. It can begin at any time. We see some people that have this type of hearing loss in their late 40s, about my age, mid to late 40s. And so, but we see some people where they might not notice the effects of presbycusis well into their 70s or 80s or 90s. And so, presbycusis is unavoidable. It occurs typically affecting the high frequencies first. So some common complaints when somebody has presbycusis is that they can hear people, they just can't understand them because they're missing a lot of those high frequency consonant sounds. And so speech is audible, but it's not always clear, so they lack clarity. And hearing aids help with presbycusis a lot. And those taking the AR class will see that in the spring. We talk about this in a little more depth. So this is the first part of Chapter 11, and we'll do the second part. Watch the videos, please, and then we will watch them, and I will go through some things on Tuesday.